All right, when you are ready, go ahead and say your name and then start.
Hello, this is Dr. Brian Pearlman, and today I have the privilege of speaking about a topic in liver disease related to primary biliary cholangitis, formerly known as primary biliary cirrhosis, or PBC. We're going to talk about some of the diagnostic issues and the treatment of the same. So PBC is a chronic cholestatic liver disease as opposed to a necroinflammatory disease. It's autoimmune in nature, and it affects predominantly middle-aged women over the age of 40. About 1 in 1,000 women from that demographic group are affected by this disease. And it's a destruction of the small bile ducts, the interlobular bile ducts of the liver. The rising incidence and prevalence is interesting, and it's unclear as to why. It could be just better diagnostic tools and more interest in this disease. Keep in mind, though, it's certainly an important and ongoing cause of liver transplantation in the United States. Now, the diagnosis of primary biliary cholangitis is really made from 2 out of 3 of these main criteria, one of which is what typically gives the clues for this diagnosis, and that's the elevated alkaline phosphatase, at least 1.5 times upper limits of normal per the lab. And of course, the most specific test is the positive anti-mitochondrial antibody, which is an antibody to the pyruvate dehydrogenase complex, but it's really very sensitive to this disease, approximately 95% sensitive. And without it, the diagnosis can still be made if you have the other criteria, which is the actual destruction, interface hepatitis with lymphocytes, and the cholangitis on histology. But most of us are getting the liver biopsy to stage these patients anyway. It's not an absolute requirement if you have the other 2 and the clinical diagnosis fits, but often the biopsy is made as a confirmatory step and at least to prognosticate. Now, there are some variant syndromes which are a little more difficult to diagnose. Notice the third on the slide is the ductopenic variant, in which there are vanishing bile ducts, and the prognosis for this one, making up about 5 or 10% of all the PBC, is worse than the average PBC patient with respect to more rapid progression towards cirrhosis and even variceal detection prior to histologic cirrhosis. There is this overlap with autoimmune hepatitis, or autoimmune hepatitis with PBC features, in which not only, of course, is the antimitochondrial antibody positive, but the anti-smooth muscle antibodies as well. Now, the titer is typically greater than 1 to 80, and the aminotransferases, unlike in pure BBC, tend to be higher than that of the ALP in terms of the phos, in terms of relative values and over the upper limits of normal. Now, the first on this slide is the antimitochondrial negative PBC. We said the sensitivity is about 95%, so you do have an occasional patient, approximately 1 out of 20 of the PBCs, that don't have a positive antimitochondrial antibody. But thankfully, at least half of them will have an ANA, and the more specific antibodies such as GP210 and SP100 are positive. Although the presentation is otherwise very similar to standard run-of-the-mill PBC, the survival is relatively worse in this AMA negative variant of PBC. So the clinical presentation is often asymptomatic. These folks do not necessarily have the symptoms, but eventually they will become symptomatic if they're followed for long enough time. The most disabling and difficult symptoms, are the pruritus, the intense itching, particularly at night, interestingly relieved with water immersion. Not clear why that is. We believe that the pruritus is related to a tumor like mitogen that's released in this disease. Fatigue is another very difficult thing to treat. And becomes a very, very common complaint, if not the most common complaint among those patients with PBC. Cirrhosis obviously could be a presentation of advanced disease, and these patients, like any other cirrhotic patient, could present with manifestations of end-stage liver disease, such as new onset ascites, variceal bleeding, what have you. The portal hypertension, as we mentioned, if the patient sometimes can present actually with bleeding varices, or at least varices seen on EGD incidentally, without knowing or without presenting with cirrhosis first, then it's sort of a surprise finding. Now, the updated management strategy is multifactorial here, and start that again. The updated management strategy is a little bit complex, but if it's broken down, it's a lot easier to follow. The baseline eval should include, of course, staging, liver biopsy preferably, although I'll show you something you can find on an app to prognosticate the patients based on various lab values and other clinical characteristics. A bone densitometry or DEXA scan is really essential because many of these patients have osteoporosis as a result of this disease, and certainly imaging, when appropriate, is important ancillary information for our patients. Now, the standard therapy has been and continues to be first-line ursodeoxycholic acid, and the monitoring would require continued ongoing lab evaluation. Sometimes, if you have access to FibroScan, although it hasn't been particularly well validated in this disease, this is a way to longitudinally follow these patients without getting serial histology, of course. These patients need to be risk stratified because some of them are not going to do well overall, and they should be cautioned about that. So getting back to urso, or ursodeoxycholic acid, the dose is 13 to 15 mg per kilo divided BID to TID. And for the most part, it's effective. It's been around for years. It's the first drug FDA approved, first and only drug FDA approved for this disease until very recently. And we'll discuss the next one momentarily. But 90% of the improvement typically comes in the first 6 to 9 months. The criteria that we use are various. One of them is the Barcelona criteria listed on this slide, in which a 40% decrease in the patient's baseline alkaline phosphatase is a endpoint that one can use. Likewise, you can use if the alk phos goes down to 1.5 or 1, really the number is 1.67 or 1 2/3 times the upper limits of normal. That's also a threshold that we say is efficacious for these drugs and becomes a clinical endpoint in many of these trials, particularly with new agents. But keep in mind, despite urso being the standard of care up to this point in first-line therapy for your PBC, then not everyone unfortunately responds to it, and approximately 40% of the patients treated with urso have suboptimal or minimal response to treatment and need further options. Now, the best part about urso, since it's been around some time, there have been good studies affirming some of the advantages of this therapy, including the improvement in the biochemistries, lipid profile, and perhaps more excitingly, the survival has improved. And that's obviously the most important clinical endpoint in which we can show that these patients' liver-related mortality improves significantly with the use of ursodeoxycholic acid, and some other data suggesting that variceal development is slowed, as is the histologic progression of fibrosis. How do we risk stratify? We're going to cover probably the more popular way to do this, because it's the simplest with the Globe app, and you can use this Globe app very easily, and there's a combination, as I mentioned before, these factors, and platelets and albumin and total bilirubin, and of course the alkaline phosphatase 1 year after diagnosis, and perhaps the age, the other factor. Here's the age. I'm going to repeat this slide in a second, sorry. So the Globe score is a good online calculation tool or app that you can use to fairly quickly prognosticate these patients relative to age-matched population or control, what the survival is for a 3, 5, or even 10-year follow-up relative to those control patients. So it's called Globe, and it's a worthwhile, simple tool to use because you have most of these numbers at your disposal, including the total bilirubin, the albumin, and the platelets. The other piece of information that's important is when you're initiating, at what age of the patient are you initiating your ursodeoxycholic acid, and then the ALK phos at 1 year of therapy, because their initial response to therapy may make a big difference with respect to how well they do. Again, many do respond to urso, but certainly those that don't, and the ALK phos is still very high relative to normal, or relative to the gold standard of 1 2/3 upper limits of normal as your goal. If they don't reach that or attain that, their prognosis tends to be a lot worse. And that is one of the factors reflected in this globe scale. So what's the second line agent? For those that have suboptimal response to URSO or can't tolerate it because of GI or neurologic side effects, this new drug is exciting because it's one of the first drugs, it is the next drug ever approved for this disease by the FDA. OCA, or beta-cholic acid, you might also recognize it as in clinical trials for non-alcoholic fatty liver disease. But for primary biliary cholangitis, it now has an indication because the phase 3 trial, about which we're going to discuss momentarily, has been successful. What does it do? It's an FXR agonist. What does that mean? Basically, by binding to that and agonizing that receptor, the bile acid homeostasis is improved. Enterohepatic circulation is decreased, bile acid production is diminished, and fibrotic, you could argue that there's some anti-fibrotic effects of this drug as well, and you can see some others enumerated on the slide there. The ultimate goal is choleresis. Now, the POISE study is an important study to at least understand the principle of. It was a randomized, at least initially, the first segment double-blind placebo-controlled trial, and actually there are 3 arms. There's the medicine, OCA at 10 milligrams, there's of course the placebo, and the third arm is a lesser dose of the obeticholic acid, the OCA, at 5 milligrams. And if the patients had suboptimal response or intolerance of ursodeoxycholic acid, they can remain on the urso. But if they didn't do so well on the 5 milligrams of OCA, or it still didn't affect a change of what you wanted in terms of the outcome, you could then titrate the milligrams to 10 milligrams per day. And the other subgroup would stay at the 5 milligrams. So it's really a placebo arm, a high-dose OCA arm, and then the lesser one that's a titratable arm, 5 to 10 milligrams. I'll repeat that slide because of noise. All right. So this trial, the OCA's phase 3 trial, is called the POISE study, and it was the registrational landmark trial on which the PBC treatment was approved by the FDA. And this was a double-blind, placebo-controlled trial with 3 arms. One was the placebo, one was the OCA at the higher dose, 10 milligrams, and then the final group was OCA at a lesser dose. But these patients, if they had a suboptimal response to the OCA, or they response biochemically, the ALK phos didn't come down, for example, then you can be either titrated up to 10 milligrams, or for those who had a decent response, they remained at the 5 milligram number. So it's really the placebo arm, the high-dose arm, and the titratable arm. And that was the placebo-controlled double-blind phase, and then later those on the 10 milligram arm were continued with an open label phase will continue for 5 years. So the primary endpoint is that threshold that we discussed, and that is the 1 2/3 upper limits of normal in the ALK phos. That's the goal, to get these patients' ALK phos down to that. Or if the bili was upper limits of normal, we want at least to see a decrement in bilirubin as well. Now here are the top-line results. Again, the primary endpoint is this ALK phos level of 1 2/3 upper limits of normal. Again, including the bilirubin number, where a 15% from baseline, or the total bilirubin is less than the upper limit. So it had to go to the normal range. So you had the ALK phos primary endpoint along with this secondary requirement, not a secondary endpoint, but a requirement for the bili to likewise go down. And long story short of this is that relative to placebo, at the end of the 12 months, you see definite improvement in the ALK phos down to the primary endpoint, statistically better in both arms, the titratable arm and the full-dose, high-dose arm, of OCA relative to placebo. So the primary endpoint, which was predominantly this alk-phos decrement, was met by both arms that received the drug. Alk-phos, here is some more specifics. Again, both the titratable arm and the high-dose arm had better outcomes and reached the primary endpoint much more often statistically than did the placebo arm in the entire double-blind phase, and continued in the open-label phase. Those were only patients that got the medication. Total bilirubin likewise decreased statistically and significantly so in the titratable and the high-dose arm. Liver biochemistry is really surrogate endpoints. Not, we believe that this will ultimately lead to clinical outcomes, but I want to emphasize that we don't yet have data on improvement in clinical outcomes. There's a 3B trial underway with these patients and others who are following out for years, and hopefully we'll have some answers. Do the biochemical improvements like those you see on this slide and the prior alk-phos decrements, does that correlate with something clinically meaningful? Because it's nice to be able to improve numbers, but we really want to see clinical events and clinical mortality benefits of using this new drug. We're going to skip the lipids and inflammatory activity. Note that the HDL did actually go down. Remember, though, that the lipid picture it doesn't really correlate at all with atherogenesis. So although the vast majority of these PBC patients do have dyslipidemia, high lipids, these are not atherogenic correlates with coronary artery disease and cerebrovascular disease. Now, the adverse events in the POISE were quite good. Keep in mind, though, it's a good thing that there was a placebo arm to emphasize again how many of these patients had pruritus that were just in that placebo arm, 38%. But please notice that the number one side effect, ironically, of the obeticholic acid is pruritus. So yes, there was additional pruritus in the high-dose arm as well as the titratable arm, less so in the titratable arm. And ultimately, both the medication arms, the arm that was titrated and the high-dose arm, both had relatively similar outcomes at the end of the trial, the closed period. So making the argument that if you want to minimize the pruritus, the best way to approach the patients using OCA is to titrate up from 5, start low, go slow, and go up to 10 milligrams to avoid as much pruritus as possible. Even in that titratable algorithm, you're still going to get obviously more pruritus than you would if you're using a sugar pill, because the drug does cause that, but it's less of an issue if you start at the 5 milligrams and go up to 10. Notice the other issues or many are similar to placebo, like nasopharyngitis. You can see that the fatigue is a little bit higher in the treatment arms versus the control arms. And nausea was less. The serious adverse events were not deemed to be related to the clinical drug in question.
Pause.
So how about the pruritus? Clearly we want to have some, if not clinically hard endpoints, we want to at least see, are you improving the patient's quality of life? At the very least, are you decreasing their pruritus? Because that's what these patients, for the most part, are complaining about, along with fatigue. And the answer is yes. Relative to the placebo-controlled arm, the placebo arm rather, there was statistically significant improvement in both the titratable arm and the high-dose OCA arm. So the pruritus was better in these patients. So the overall findings of this phase 3 trial with obeticholic acid for primary biliary cholangitis are as follows. The effect was consistent, independent of the age of the diagnosis, and we didn't go into too much of the nitty-gritty, but it didn't matter with respect to how long the patients were on it, the actual age of the diagnosis, whether they were younger or older, and what the baseline ALP is, alk-phos, because the patients did well regardless. The titration, as we mentioned, was probably better in terms of tolerance. It minimized dropouts due to pruritus and showed comparable efficacy at the 1-year point to the high-dose OCA arm. So there was obviously an advantage of doing the titration because you get the same bang for your buck, but you're actually having fewer side effects. This drug is recommended for PBC patients in whom the response is inadequate or suboptimal, or unable to tolerate the ursodeoxycholic acid, which remains the standard of care in first-line therapy. There is a clinically meaningful number improvement in biochemistries and alk-phosphatase. However, again, clinical endpoints we have yet to show. But since the surrogate markers are down, we believe that there will be a clinical benefit, but to be fair, we have yet to have that data available. Nonetheless, the FDA approved this medication as a nice alternative and as a second-line option, strengthening our single drug armamentarium for the direct treatment of primary biliary cholangitis. So the indication, again, to make it very clear, is PBC in combination with urso, or if they're intolerant of urso, instead of urso, or as monotherapy in that case. But you know, the alternative agent, it's nice again to have this second line agent or alternative to the first line agent, and we haven't had that heretofore. So this is nice and exciting to see finally another option or add-on option for those who, the 40% of whom that just don't respond to urso. The long-term management per the AASLD guidelines for primary biliary cholangitis, liver tests should be performed every 3 to 6 months, meaning these patients should be seen in the office at least twice a year. TSH should be done because these patients tend to have hypothyroidism, and you don't want to miss that. The bone densitometry, DEXA scans every 2 to 4 years is a very reasonable recommendation, again, because the association with this disease and osteoporosis, osteopenia. The patients with advanced cholestatic disease, such as high bilis over, say, 2 or 3, these are the patients that truly do need fat-soluble vitamin levels, such as carotene for vitamin A, coagulation parameters for vitamin K, and vitamin D levels, which should be monitored. So how about those that need the upper endoscopy? Remember, we do this reflexively for patients that are cirrhotic, but remember, some of these patients can actually have varices, even irrespective of cirrhosis, and perceive the development of cirrhosis. So certain things may warrant their being surveilled, including low platelets and a Mayo risk score over 4.1. Of course, like any other disease that causes cirrhosis, these patients that are known to be cirrhotic should be monitored for hepatocellular carcinoma. And many of us have jettisoned alpha-fetoprotein because of its poor specificity and the multitude of false positives that lead to more tests and, more importantly, patient anxiety. So many of us are simply doing imaging tests, the cheapest and easiest and safest being biannual, or I should say twice yearly ultrasounds. And with that, I'd like to conclude and thank you for your attention today.
All right. Good job, dude. You look relaxed.
I try. This topic is not the most